We are the dentist of Shea Dental.
I'm Dr. Alan Siegel, and
I'm Dr. Kristen Graham.
Frayvon Malay.
And Dr. Josh Rafey.
well, I decided I was in construction when I was in undergrad and decided I liked working with people and working with my hands, so it seemed like a nice thing to do. And my orthodontist talked me into checking out dentistry when I was 16. So from about 16 on, I knew I was going to be in dentistry.
I have family in dentistry, and shadowed family growing up because I needed a summer job, and I fell in love with it. And along the way, I figured out you can use your hands, use your brain, and own a business at the same time. It's kind of a great combination of all of it, and so it just naturally led to it.
My story is similar to Dr. Siegel's. I started working in ortho when I was probably 14 years old, became an assistant when I was 17. My boss at the time was like, let's just see if you like this. And I loved it, loved helping people. And so that led me to dental school.
Oh, very good.
Mine's a super long story, like always, so I'll try to shorten it up. But I think I could say I almost knew from either 4 years old or 5 years old on.
Aww.
But it's only because my dad sat down with me and he was teaching me how to read and write on a chalkboard. And he kept talking about, I think it's his second cousin's a dentist, and he just thought it was the best job ever, the best profession. So it was in my head. And then I did some other things and didn't think about it through high school. Went to Hawaii, did some stuff, and then realized, you know what, I need to get back to that. But similar to you.
Yeah.
The same type of reasons. Work with your hands, have your own business, dealing with people.
Yeah.
You know?
I think we'll go into maybe kind of what you like to practice, kind of what your areas of expertise and what you really have a passion for.
Well, I like doing build-ups with crowns and things like that, and trying to get people's bite back together and trying to work through those problems with people.
Yeah, I think my favorite part about dentistry is really just helping people, and especially in the holistic world when people have been through really hard sicknesses or toxic exposures. I love helping them get their health back on track, and I love working with my hands. Yeah, it's great to help people.
Yeah. I like helping people too. My favorite part about dentistry is especially the aesthetics and the cosmetic side of things, especially when they have like really poor condition of their teeth, whether it be through abuse or a lot of decay and cavities or just ground down, worn, helping people get their bite back, but also just the functionality and also making it look great at the same time, getting that $1 million smile back.
Yeah.
And combining that with technology, such as the CEREC and the same day stuff, and obviously the laser fillings. But when you can make a tooth in the other room and 10 minutes later you can put it back together, I think that's one of the coolest parts about dentistry.
I agree with you.
Yeah.
The CEREC is amazing because even maybe 5 years into practicing, I was like, oh, this is getting a little bit boring. But now when you make it yourself, it's so artistic and it's so fun and creative, and you get to shape it and design it. You really can take responsibility and own what you're creating.
Well, both, for example, like, you had all those years that you would do a crown, for example, and to the traditional prep it, impress it, send it out, temporize, 2 weeks later, numb, get them. I mean, and then you've had the CEREC for the last 2 years now.
Yeah, it's definitely an improvement. And, we were talking earlier about just doing onlays and stuff. And after 38 years, I was, doing fillings and stuff. But really, I was always telling Carla that, for all those years that, I didn't like that there was mercury in the fillings and stuff. But I also wasn't really happy about the white fillings having all the other chemicals that are in the white fillings. And then we were talking the other day about we should be doing onlays, making it out of porcelain and skipping, the white fillings that are just breaking down also. They just don't last.
Yeah, and those white fillings really were only ever designed to be used in front teeth. They were never designed to be used in posterior teeth because they're not strong enough.
Yeah, so you changed my opinion on something that I had for 38
great.
years.
Look at that. Yeah.
It's working.
Yeah.
Yeah, for me with the CEREC, I'm not doing that so much as you all are, but I see them. And to me, the biggest thing, besides everything you're saying, is the margins. They're insane. And I think that marginal leakage is one of the biggest problems with posterior composites. You're getting that for sure. But with those, man, they fit like incredible.
And
even the crowns, like you almost can't detect it.
Right.
It's pretty impressive.
And they don't shrink. And that's why I like to really explain to patients in the chair. And it's like, hey, if there's a filling, especially for posteriors, because they were not designed for posteriors or the molars, right?
Nope.
Unless it's such a small filling that you're like, of course, little hole, sure. But if it even gets even remotely bigger, you don't want it in your mouth. I don't want it in my mouth. It shrinks through the nature of the material. You can't do anything about it.
That polymerization.
Polymerization.
And so you're layering, you're taking all this time, and you're still losing it.
In a couple of years, you're like, hey, now it needs the onlay.
They just don't last.
They just don't last.
And then in the meantime, if they're clenching and grinding, which most people are, then they break it or they break their tooth, and then they need a crown or onlay anyways.
And they've lost more tooth.
Right.
Yeah.
Yeah. Yeah, for sure.
Yeah.
So I feel like it almost feels more aggressive up front to the patient, but long term it's actually a lot more conservative.
But then it's also can be conservative because at some point you'd say, well, this tooth might need a crown, but you could do an inlay or onlay instead, and now it's so it depends on that situation.
Definitely.
Yeah.
Yeah.
I mean, when you do a large filling in such a large, it's gonna shrink. There's nothing you can do about it, and you're gonna need something on it anyway. So it's just the fact that we can do it. But I think one of the great technologies that, of all things, you've had for probably the longest is the laser.
Yes.
In terms of the valley, in terms of the country, you had the laser since what, 2005? 5?
Yeah. And we thought that there was going to be this tremendous push for everybody to have one. So we got right in there and got it. And then now there's nobody.
Yeah.
Nobody's using them.
Not many.
Not many for sure.
Yeah, I think dentists are just scared to use lasers, basically.
How did you get into it, of all things? 20 years ago, how did you, of all people, get into it and start utilizing it?
In undergrad, a friend of mine was doing laser cancer research and stuff. And we were sitting there in a movie theater and redesigned how we could use the laser to just hit cavities, because we could just stain the tooth with the laser that's already designed for that frequency and have it hit just the cavity. We came up with that idea 40 years ago, and you can see that really worked. That really caught fire out there now. But, still out there to do. There you go. I just gave you an idea if you decide to like push into lasers. So it goes all the way back to when I was in my early 20s. So, and I don't know, not scared of the thing now. I mean, I take the laser and I point it at my hand and I show people that, that it doesn't make a hole in the glove.
As long as you're far enough away.
Yeah, I don't tell them that part.
Do you hit it? Do you start it? You hit it the laser?
Yeah, then there's water all over the floor.
As long as you're far away, though.
Yeah, I'm this far. Yeah, defocus it like out here, and it just drips water all over the floor. And the assistant's like, "Well, thanks. Now we got to clean that up."
So, speaking of doing it on your hand, I was working on a mother, and they had this little 4-year-old son there, and I was like, "Oh, check this out!" And I put some material on I put a glove on him, and I put the material. I say, "Oh, it's soft and it gets really hard. You want to see it?" And he goes, "Yeah." So I put the composite on there, and then I hit up the light, and I forgot that the light's also really hot, and he starts going, "Ah!" And I'm like, "Oh, yeah, my bad." He was fine though. It didn't work. Yeah,
That's so cute.
Yeah. So if you try the laser, don't put it like
yeah,
that.
you went like that.
I know that.
Yeah. Out here is fine.
Yep.
What's the funniest thing that has ever happened to you in the chair, in the room?
Oh, I got one.
Okay.
So for me, what?
No. I don't have one, so I'm glad you do.
I have one. So I was actually, it had to do with amalgams, and I'm getting an amalgam out, and there's probably better techniques, but I'm taking this thing out, and I've got a regular mask on. So I'm kind of taking it out, and you know how sometimes you take it out and it'll catch, a piece of it might catch your burr, and you can hear it ping off the wall or the ceiling or something, like ding, ding, these things are flying around. So I'm doing it, and I'm like, all of a sudden, I'm going along, and all of a sudden, something hit my lip. I wasn't sure what it was, and your first reaction is to lick it.
Oh, no.
Guess what it was? It was a person's amalgam. So now it's in my mouth.
Oh, my God.
And I'm sitting here working on this person. And I'm kind of spit it out and try to pretend nothing happened. But to me, that was one of the highlights of my career.
How did it get through the mask?
Through the side
Oh,
somehow.
my God.
Wow.
Like it probably bounced off something and right into my mouth. well, right on my
Couldn't
lip.
have tried to get that there.
No,
if you
Mike,
wanted to.
it's never happened since. I've been hoping, but no, it's never happened since. So, no, that was fun.
That's
So
so
I don't know. I got nothing that's that funny.
Funny or gross.
Yeah. I think taking off old bridges, for example, sometimes it sparks a little bit. Mm-hmm. You just have to stay.
Especially zirconia.
Oh my God. You just have to stay stone cold because patients can see the sparks coming out, obviously.
Yeah.
If it's like enough metal or enough burr on metal enough, sometimes sparks a lot. You're like, wow. And you just have to stay stone cold and be like,
Yep.
this is normal.
Everything's fine.
Everything's fine here. This is planned.
It's actually kind of one of the difficult things about being a dentist, I think, is that just think if you're the patient and this happens. I mean, you're working in the garage doing whatever you're doing and something goes wrong and you say, oops, or you say, or you grunt a little or something. You can't do that ever. If you do that ever, the patient's going to think, well, something went wrong. And maybe it kind of did, but not really. So you're always trying to keep your composure and keep patients comfortable, which that's one of the parts of dentistry I kind of like is doing the surgical stuff, and pulling teeth, but to somehow do that and have it not be traumatic for the patient is a challenge.
There's a
challenge to that.
Well, I can remember something funny now. So,
Speaking of which,
we all have the same problem because we all wear masks. And so our patients think that we're mumbling to them. That's pretty common.
Yeah.
And we probably are. So I remember saying something about somebody was closing, and I said, wow, you almost bit me on that. So she bit down, and I still had my hand in her mouth. So she bit my thumb, and I had to tell her to open, to let my
hand go.
oh my God.
Yeah,
I've never
then she
been
told me
bit,
not to mumble.
really.
Oh my gosh.
That was her warning to me. Don't mumble.
Otherwise, I'll bite you.
Clearly, I learned a lesson there.
I was just going to say, you probably learned.
So I'm just warning you in advance.
Okay.
Don't use
mumble.
the word. Yeah, don't ever say bite.
Yeah.
Unless you're ready for it.
Yeah, I don't
Get your
even say
hands
that.
out of
I
there.
just say close or something. I don't
Yeah.
use, that's a trigger word. I don't like.
Yeah.
I tell the assistant don't say bite ever.
Yeah. Yeah.
I think
There's a lot
funny.
of little tricks.
I think I have the exact opposite problem with you. When I say bite, such as the bite paper, and they're like, what do you mean?
They'll bite on the front teeth.
Yeah,
how do you
there's
normally eat?
that.
Like you normally eat a steak. I don't eat steak. Well, you know what?
I don't know.
You
Apples,
should. You
what
should
do
eat
you
steak.
I don't know what to do here at this point.
Yeah, it's that part's messed up in dentistry, and there's no good answer.
Yeah, no good answer.
Just
We are
Yep.
watch your fingers.
Yep.
we are the one medical profession that actively does surgeries and even fillings and crowns and obviously root
That's
canals and
still-
surgery
that's still
is still a
surgery stuff.
microsurgery
It
of some
is.
form. And we're the only profession that has to do it while they're awake,
Yeah.
looking at you.
That's
And of all
so
places,
interesting.
it's in their mouth.
Oh,
Like what more
very
sensitive area is
vulnerable.
there?
Yeah, so just remember.
Yeah.
one of my instructors at school is a really cool guy. He was a ward worker,
Yeah.
and he actually chopped off his thumb. And
Woodworking.
Woodworking. He was a full-time professional dentist. I'm like, how do you do it? He goes, sometimes it's hard.
Yeah.
Wow. Wow. Good
Yeah.
for him.
Yeah.
Feeling heard and listened to and cared for.
And I'd go along with that because what I was going to say, it's that's more real to me. It sounds harsh, but like getting what they want, but they want to be heard and say, hey, this is kind of what I want to do. And it's somewhat of a challenge because sometimes it may be that they want ozone that might not actually be effective. And so now I want to give you what you want, but I also want to give you something that'll work.
Right.
And so to me, it's like them being heard, but then also trying to take that and guide it a little bit to giving them what they want and need. And it can be a bit of a challenge. And I think that's really fun in your office is that you do have that holistic side to it. And what I found is up to that point, it was always like the whole thing, oh, they have periodontal disease. I can't give you a regular cleaning type of thing, because it's not going to work and it's supervised neglect, all that kind of stuff. But at the same time, I feel like even sometimes if I'm not completely on board, but I know it's not going to hurt, I really have enjoyed giving people what they want. Hearing them and just, give you what you want, as long as it's not damaging,
Yeah.
of course. But
Yeah,
Yeah, a lot of times you can try it and see if it works.
Yeah,
If it doesn't work, then they're more on
fine,
board.
as long
They're
as
like,
you
okay,
haven't-
I hear you. I
Yep.
understand this didn't work. We can move to plan B.
yeah, yeah.
I think going on top of that, it combines both a bit, but safe. They want
Yes.
to feel
Yeah,
safe.
safe.
Heard. Let's try an alternative,
Yeah.
and also, hey, as long as you're safe.
And safe
Hippocratic
also.
oath.
Yeah, I think that also means trusting your provider. That's why I really like how we do it, where we get pictures, we get the CT scan, we show them everything that's going on. That way it's just not take my word for it and trust me without hardly knowing me. It's this is what we're looking at. You can see for yourself. I think
Yeah.
that really builds rapport.
Transparency. What do you think?
I think I have to get out of the chair all the time and point to the on the monitor and say, "Here
You
it
have to get up
is.
and
This is what's going on here. See that?"
Yeah.
And, you know, that's okay. I'm glad you bought really
Do you
big
ever
ones.
show?
Yeah,
do you
they
ever
appreciate
show
that.
decay? Do you ever show like the
Always.
cavity? You know, in dental school, I remember them telling us not to do it. Of course, back then, I guess it was because there were those tiny
Oh,
little things.
yeah.
Maybe.
Yeah, well,
but that's so effective. Like, look, there's the
is.
dark spots. Like,
Well, I
you can
get out
see
of
it
the
too,
chair and
and
I
they
just point.
understand.
I touch the. That's why there's marks on the monitors. So, because I touch with my finger.
See right here.
There's not marks on there.
You need to get one of those. I don't know if they make them those little remote.
Oh,
pointer thing.
laser
Oh,
pointer.
yeah.
It's
Just like,
okay
see
for me
there?
to get out of the chair
It doesn't hurt.
and walk around the room. And
You're
go
not
to
that
the,
old, Dr.
Nice to get
Siegel.
up.
It's all right. I'll do that.
Oh, is that what he was saying?
Yes, I think so.
So funny.
I think that's what he's alluding to.
Yeah, I don't want a pointer. I'll just sit back here. Please, like right there. No.
I gotcha.
That's funny.
Yeah, you don't see me getting out of the, like walking around the room. I'm always doing that.
You are. Yes, you are. Wow, that's a really big question.
Tinfoil hats and
It better be more than oil
of
pulling.
course.
Yeah.
Yeah, it is.
Or we're going to have an argument.
It is. Oh, good. I love those. Let's go.
I should say discussion.
Yeah. So holistic dentistry, from my perspective, would be looking at the whole person, their health history, and then treating them the way that's going to be the best thing for them long term. Looking at their health.
So not like a tooth technician. Almost like a
Correct.
real doctor because you're looking at
almost
everything.
like a
Beyond-
real
yeah.
doctor.
Almost.
Yeah, looking at the whole person. So, like for an example, is root canals is a hot topic. So, a person comes in and maybe they need a root canal. Instead of being like, because there's a whole spectrum of dentists, right? So some are like all root canals are safe and fine, and then there's some holistic dentists that are like all of them are poisonous and going to cause cancer. So I feel like I'm kind of like a little bit more over here, where I address the patient, look at where they've been, what health history they have. Do they have a history of cancer or autoimmune disease or, just a long list of toxic exposures throughout their lifetime? Well, if so, then adding this root canal, yeah, it's definitely an option, but it might be too much of a body burden for them, and that might put them over the edge. So it could be the straw that broke the camel's back. So then we look at just the whole person and deciding what's best for them. It's not just a scripted one-size-fits-all program for each person.
I like that because for me, I've done, well, one of the things I do is root canals, right? But it's been very thought provoking for me to say, man, you know what? Because one time you said, it seems like a lot of them have some pathosis or like periapical parl or something. There's always seems like there is a little bit of something, and that one's a little bit of a struggle because I feel like hopefully I'm not doing too much damage, but if you could save it that way at first, well, you can always still pull it.
100%.
But with everything that you're saying, well, how long do you want to let that go?
Right.
So that's one of the things that for me has been different, where if a patient comes in and I'm like, man, I could save that tooth with a root canal, but they don't want that.
Right.
Okay.
Or what's the cost going to
Or
be?
what's
if
the
you do
cost going to be?
save
Yeah,
it?
and then if you
Yeah.
do, and that's another good point because you could say, well, just do the implant, and you're generally going to have that the rest of your life. Or we do this, and it might last you
A couple years,
maybe you get 10, maybe who knows.
But then you're going to be at the same spot
And
again.
then you gotta-
we'll
and
have
then you
you
gotta spend
having
the
the
money
same
again.
discussion in 5 or 10 years down the road.
And retreats
so,
are a lot like that. So you do
Yeah.
a retreat, like, gosh, you've already thrown everything in the kitchen sink at this tooth, and now you're going to try to do a retreat too. And what's the success rate there? And is it
Lower.
really
Lower
right?
than
I'll
initial.
say that, after all these years of doing this, what I found is that you probably have a very good point that every root canal that's done, it could look perfect and it could be in the trash can after a short
Oh, and
amount
how
of
many have
time.
you seen that
two,
look
So
two
you-
to 10 years,
So,
Yeah.
could be
even less.
less, yeah,
Yeah.
and it could be the failure part of it could be from that. It could be all kinds of things medically that You know, we have some implants that won't, you know,
Yeah.
they keep taking the implants out and putting new ones in, and then they're taking those out. It's just some people have medically, they're just not
a
going
candidate
to.
for everything.
Yeah, it's just not 100%.
Now, I will say, like, one of the beautiful things is having a CBCT. You're looking at it in 3D, so on the root canals and implants, it really helps the success rate. But you're looking at it, and so I can at least, with the root canal, at least it's hard to miss an MB2 canal or whatever it is, because you go down that tooth. I like going coronally to apically. I think you like going laterally a little bit more.
Yeah.
I'm trying to get that down too, but just going straight down it, I can just follow those canals, go, oh, look, it joins together, or this one's kind of going off this way, or it goes down and splits. Maybe not a root canal that's going to work. So
Well,
that,
even if
I
you
think,
get all of
increases
that,
it.
though.
Oh,
there's
totally.
There's still the other factor.
I know.
that the holistic part of that needs to be factored in.
But at least we're able to do it in a way that is, I think, more predictable than it was when I first started
Yes.
doing them.
Yes.
It's at least that. Like, at least I know I'm getting them all. And then if it doesn't work, or the other factors, maybe you don't do it in the first place. But at least you have I feel like a lot more information, a higher success rate in general.
Well, when
because
I
of
was
that.
in school, there was upper first molars were 3 canals and not 4.
And not
it's
4.
Now it's what, 70 or 80%?
That on a first molar, upper first, that you're going to have an MB2.
Yeah, well, that's not what they were teaching.
I know, right?
So
So we were missing them for years and years.
that's not the way I was fixing them.
So at least they're better
38
now,
years
but
ago.
are they for everybody? Probably not.
Yeah.
Yeah,
It's worth the discussion with the patient.
it is.
So that's why I gave them to you.
Well, I don't mind them at all, but I think in a way, when it comes to predictability, man, the implants are just so good,
So much better.
so much better. And so, do I prefer it? Yeah. Plus, I think the whole procedure and how easy it is on patients, like, they don't realize taking a tooth out is pretty traumatic, but putting an implant in is nothing. Most of them don't take any like, they don't have any pain afterwards. They don't take anything. It's kind of different.
I think a good topic next would be zirconia implants versus traditional titanium implants.
Boy, I got some
Let's go.
opinions.
Let's go. Let's go.
That one's a little tough to say for sure, because a lot of it's by experience, and you can look at studies and whatnot. But for me, what I've noticed with the zirconia, especially in the anterior, I mean, why wouldn't you?
Right.
If you could, like, why wouldn't you? Because now you've got a white implant that, even if you have, because it's hard to control the gum line, and so you might get a little bit of exposure of the implant. Well, if it's a titanium, you've got this big dark line. And that's another thing. If you have a high smile line, you might not even consider an implant at all, because it's so hard to manage. But the zirconia at least help with that. The other thing, and this doesn't matter to anybody but me, but the placement of the zirconia is, it's more technique sensitive, but it feels more predictable to me. It does. It feels more predictable, because you get in and you're kind of basically tapping or threading the bone a little bit and then putting it in, and it's not as much torque, and it just, they fit like a glove. Like, they're super fun.
That's great.
Yeah,
That's great.
They're nice. They're nice. Where I'm not sure is when we talk about tensile strengths and compressive strengths and things like that, where if you're in let's say you're like some 250-pound guy with a great big pit bull jaw, and he's grinding, all his teeth are flat, and you're putting a zirconia in tooth number 30. Not so sure.
Yeah.
That gets me a little worried. But I don't know, because I haven't
Done enough
done enough.
and tracked it long enough.
Also, they haven't done enough for them to really know
They
long term.
really haven't.
Are you sure they haven't? Because they've been using these in Europe for like 20 something years.
Yes,
So
the booth next to me at the conference, I get the letters wrong. So what is the letters?
IAOMT.
Yes, I'm at that
Sponsor us.
at that conference, and the gentleman next door to me, he was the, founder of the zirconia implants. Everybody in the whole place knew who he was. They're all coming over
in
and
Switzerland?
seeing-
Was he from
SDS?
Switzerland?
Yes,
Yes.
yeah.
Okay. I'm blanking on his name, but I know exactly who you're
and
talking about.
he won the drawing that we had, so he got the drone.
Oh wow.
It's like great. So
Yeah. So what did he say? Did you ask him about them?
no,
Oh.
He wouldn't have been
I
biased
just was
at all.
told that, and then
Yeah,
I
no.
talked to him every day, so it was like, he's really nice.
Think there'd be a difference between American patients versus European patients versus average master strength, long-term prognosis in a zirconia implant.
I mean, people in Europe are probably healthier, and their
Probably.
vitamin D is probably higher, which probably means they have a better prognosis for implants.
Yeah.
Yeah.
But
But they're also, I don't know if this is totally true, but the office that I bought years ago in Scottsdale, the dentist was Albanian. And so he would see a lot of people from Europe. He had a lot of contacts with Europe. And according to him, one of the things that they would do there too is they'd place implants actually into the sinus. So this is why I was saying, like, sometimes with what they do in Europe, it's not that it's bad, and maybe they're kind of on the cutting edge a little more, where we're kind of more wait until everything's so I'm like, yeah, let them figure it out there. But the ones that go into the, so I'm not, so if they do something in Europe, I'm not always like, well, hey,
is it perfect?
then we should
Is
do
it
it.
great?
Because
Right.
they do some things that we probably wouldn't do.
Right,
But
that's
having
true.
said that, I've had patients that didn't want the sinus lift, and I knew that about the Europeans. I was like, just don't sue me because it's not in accordance with the standard of care here, but let's try it. And I haven't had one fail. And I'm not saying we're putting it a mile into the sinus,
Right.
but like you bump
little
it,
bit, yeah.
maybe you go in a couple millimeters, never a problem. I've
Wow.
even placed some where you have like maybe 4 millimeters of ridge and then you have the sinus, and I do like an 8.5. So a good portion of that, more than half, is in the sinus. Never had a problem.
Wow, that's so interesting.
Yeah, but I think the theory is that those epithelial cells can come down and migrate.
Makes sense.
And then stop the bone from actually adhering, you know, because it grows faster than bone.
Well, they also
osseointegration
they
kinda
also
stops.
can bridge an implant to a natural tooth.
So I just did it in an office, and he's done a lot. Now, Gordon Christensen, don't want to necessarily speak for him, but I took some courses that he's given, and one of them he talked about that. And they used to do like a key way to try to stress break because you're worried that the natural tooth won't get stimulated enough, or the implant gets too much, and one of the two fail. So you put that little stress break so it can kind of move.
That's interesting.
But apparently, recently, that's not even been proven to work much. And Gordon Christensen says, and he probably has, he's like 80-something, that he's done thousands of tooth-to-implant bridges without failures.
Without keyways?
Wow.
Without keyways. So
We have one patient that I know of in our practice that was placed by Judson up in Utah. Zirconia to a natural tooth.
Oh, really?
It's fine.
yeah,
Awesome.
yeah, I think
I
they
will
work
say
well.
that I will say it does have recession on the implant, zirconia implant.
Oh, does it?
Not a lot, but a fair amount. But it's integrated. It's steady.
Well, a lot with that too, and you probably all know this, but in the other offices, I want to have like a little sit down and discuss this. So I place the implant, and I'm not putting the crown in, but it's really important when you place the crown to have the occlusion right. So you can't like have a lot of lateral excursive contacts on it, and you want to get your main point of contact to be directly over the implant, even if sometimes like you have to chase the bone. So the implant's over here, it looks a little crooked or whatever. It's really chasing bone. So you're trying to get it right over that. So you might have a crown that's here and the implant's over here. Your point of contact should be right in line with the long axis of the implant if you can, without excursive contacts. And so when you do the occlusion, you have them do their bite and everything, you get it there. And then after you think you've got it, you need to have them clench hard. And that what you want to do is not have much occlusion whatsoever until they clench hard. And now you've protected it. So if you do that in that, especially with a bridge like that, you've got to be super careful, or you might get that recession because it's putting pressure on it. And that's what I think really causes the failures. But that's just implants in general.
Yeah.
Well, the good thing is, even though we're talking about it as a possibility, it's incredibly rare that I've seen natural teeth attached to an implant.
It's rare.
So
or
before you all go down
sinus.
that road, I would probably not maybe do that.
Yeah, I like almost never do it, but there's some situations where, the one that we're doing is we were trying to do 2 implants in the upper maxilla, and one did fail, but that was an immediate on number 3. Those don't always work super well anyway, but they have number 2, and it's solid. And so we did the one in the area of number 5, and we're like, what do we do now? Do we do this again? Do we do a sinus lift or try the bridge? And so that dentist felt comfortable with it. He's done a bunch, and patient did too. But I don't think it should be the go-to.
Well, yeah, just because that other group of people that decide for us
I know.
will not be with us.
Well, not. I know.
So,
Weren't we just at a lecture or something that because osteoporosis drugs are increasing in popularity, that we're seeing that people who've had implants for 10, 20, 30 years, totally integrated, totally fine, that once they get on these osteoporosis drugs, that actually over a few months, if not a few years, they actually have implants coming out. Have you guys
No,
seen
but
this
I-
data
no,
yet?
I
Were we
believe
somewhere?
it.
We were.
I don't know if we were on that, but that sounds reasonable.
Is that like
to
the
me.
bisphosphonate
Yeah.
thing?
Yeah,
Yeah.
I would think that's a definite possibility.
Yeah.
And obviously, we all know if they're on bisphosphonates, no surgery, no implants, nothing. But people aren't talking about what if they've had implants for years and then they start bisphosphonates. We're starting to see a lot of uptick
Yeah,
on
I believe that.
rejection of implants that have been there for 10 to 20, 30 years.
Interesting.
Yeah.
Yeah.
Food for
I've
thought.
seen maybe 15 people over the years that the area just doesn't heal. So it doesn't surprise me that they,
Yeah.
going backwards, once you have it in there, who's to say, if you're not generating the cells you need to repair it, then why wouldn't it fail?
Yeah.
Right.
I didn't know that.
Yeah.
That's interesting.
Yeah. We'll
That's-
let them two talk about
Well, yeah.
PRF,
Do you wanna
ozone
go?
and lasers. Yeah.
I've been definitely doing a bit of that. I feel like I need
Yeah.
to hide my shoes. The camera gonna pick up these shoes?
PRF. Yeah. Okay. So PRF is platelet-rich fibrin. So when the patient comes in, we draw their blood, we spin it down, we extract that from it, and then after Dr. Millay does the surgery, you put that basically clot into the socket, and then it helps basically takes the stem cells and it stimulates the bone growth and the healing and the regeneration of all that tissue there.
Yeah, and all those white blood cells are concentrated. What I found is interesting. I'd done it a little bit before coming here. How long have I been with you now? A year?
Here.
Yeah. So I had done it a little bit before in one office, but I didn't get to really see the results. And now I've been able to long enough to see the results because you come back in, you do that, maybe you're doing the implant or something. So I got to come back and look at the bone and the levels and the width and all that. The only thing I can say is that I've been absolutely shocked, shocked, because I could do a bone graft and do the membrane, get it all perfect, even tie the membrane to periosteum, like it's not coming out, it's going to be great. They come back and it's like, that didn't really, and again, it's patient by patient, but
Right.
over the years doing that so much, I don't think it is nearly as predictable. The PRF is like just crazy. They
Yeah.
come back almost every time. It's looking fantastic.
The other thing, when I was doing extractions, did you notice that the patients that got PRF hardly had any pain?
Oh yeah.
They were
well, they heal so
significantly-
quick.
Yes,
They heal
significantly
so
reduced
quick.
swelling and pain. It was just much
They'll
better.
come back for the suture removal, and you know how you'll do that, and a lot of times you're going to see a pretty good little pit still, and it's like they're worried about it. Like, no, don't worry, it's going to fill in, whatnot. With PRF, a lot of times you've got like this sort of like healing plug, if you want to call it that, but it's even with the gingiva.
Yep.
It's not like it's 3-4 millimeters deep with a big gaping hole. Many times it is even, and it's already filling in. It's pretty wild.
It's amazing.
I don't even know if you have to keep the stitches in long because of it. It's so good.
Probably
Oh, and the membranes you can make with it.
Yeah.
That's the other thing. So
Yes.
you're not putting anything foreign. It's their membrane. So the PRF, when it comes out, it looks like a snotty little slug. Like it's kind of
Yeah.
gross.
Yep.
And then you can flatten it and make a membrane. It's really resilient. So you put in all that bone graft and then tuck that in, in between the bone and gums,
Suture.
and then suture over the top. But even in my hands, handling that is
It's easy.
so easy.
It's
Like
easy.
it goes in really, really nice. Whereas the other side, it's like slipping around. It might tear. It's just a complete nightmare putting a membrane in. But that is the best ever.
I agree.
It's so
No,
good.
we're not getting calls either on weekends for people that when you've taken a tooth out and put that in. I'm not getting a calls. I haven't gotten any calls on,
Yeah.
Yeah.
on
I got
anything
you.
like that.
I got to a
Yeah.
point where I wouldn't do extractions if the patient didn't agree to do PRF. Because I'm like, it's just going to be so much better for you. I can't do this.
Yeah,
without-
totally.
Yeah,
The only
totally.
issue with the
It's-
PRF is I need to get better at it. Fortunately, we have Val to do
Yeah.
the blood draw.
Yeah.
Because sometimes I get a little sketched out. I was like, I can't see a vein. We want to do it, but am I going to be able to do it?
Yeah.
You got to get the blood. But it makes sense. Like you're putting you back in you. How
Right.
could it be a
Right.
bad thing? Now the ozone part of it, I couldn't say that I know that that's helping. It makes perfect sense why it would, but I don't know because I'm doing both concurrently.
Right.
But I know that together it's working, but I don't want to do one and not the other on somebody and test it out. And the ozone makes sense. Like you get in there and clean everything out in the socket and then flush it really good with ozone. What are you doing? You're super oxidizing anaerobic bugs, right? So
There you go.
how could it not
It
work?
can only help.
Yeah.
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 What's I think we should talk more about, because what time is it?
Hold on.
You got 10 minutes? I think we should talk about what's our favorite part about,
Oh.
time flies, we're having fun. But what's your favorite part about our office, our team, working with our patients, you know, versus like other offices?
I'm going to do all the talking because I'm all
for
over
it.
the place.
Well, you know, I mean, I use the laser probably 2 times a day, you know, and they walk out of there without having anesthesia, and they're all, there's the running joke that I have 30,000 fillings that I've done, and everybody's like, well, they're 30,001, but we've been at that number for another 5 years.
Yeah.
You know,
But not a lot of other offices are doing that, which
Right.
sets us apart.
no. So how did it go the other day on your soon-to-be?
With the laser, we could get part of the way into it, and then I did have to pick up the drill, which I did warn her about because it ended up being a lot deeper than we expected.
About the one I did.
Yeah, easy.
Yeah,
It
you
was
didn't
great.
hear anything.
Yeah, no complaints.
Yeah.
And most of the time, that's how it goes. It's just if it's deeper, then
Right.
yeah,
But maybe not. Yeah, that's why I have a lot of techniques.
exactly.
Yeah, he was in and out in 5 minutes. So.
Yep.
Well,
But
maybe
it,
10
great.
minutes.
it does make you question things. If like, okay, I can use filling, and if I can do it with the laser, great. But you start asking yourself, if I can't do it with the laser, why am I not going for the onlay? Where there's obviously
Oh, for sure.
there's
Now
obviously that
you're-
middle ground that you
Right.
need the anesthetic and a
Right.
filling.
But if you're that deep.
If you're that deep, but then there's questions of, well, if I'm already that deep, so it's such a great way to practice where you're like, okay, look, it's small enough, I don't have to get you numb.
Right.
If it's big enough, it's going to last you 3, 4, 5 times as long, so you don't have to do this ever again.
Right.
Yeah.
It's a great way of practicing too. Yeah. What about? I think I want to talk about more about our culture at the office and our great team.
What I love about it is that everyone is willing to help each other.
Yeah.
I can talk to the doctors about a case. I can ask the assistants to help. The assistants will help each other. Everyone is on board. It's a very, everyone has a servant heart in the office. It's really beautiful and really rare.
It is rare.
People aren't fighting over, well, she did this or she didn't do this, and I'm mad at this person. There's no drama. There's no gossip. It's just everyone wants to help each other.
I don't know how that's possible.
It's so
But
rare.
it's because
It is so rare.
because I'm still running around the valley doing things in different offices. It's never like that.
It's never like that.
When we had our first, Carla, I think the first office meeting I went to, and I remember, I think people were asking, how's it going? What do you think? And that was the first thing I said.
Mm-hmm.
Like it's more the kind of the culture.
It
It's
is.
a good vibe.
Yes.
A really good vibe.
And the leader sets that. So
We
So
try to
somehow
set
you
it.
did it.
Yeah.
good. Well done.
But I have to tell you, I got the 3 assistants are like avoiding me on changing that trap in the They're like, oh, I'm busy. I think I'm going to do my nails.
So there are some issues.
Like, yeah, I don't want to go near.
assistants when it
I
comes to
don't-
certain things.
I don't want to go anywhere near that thing they're saying. I'm like, well, I'll show you, but I'm not doing it for you.
Crazy how quickly the time goes in between the trap changings.
Yeah, just don't open that cabinet up.
Oh God.
It's funny.
If we don't open the cabinet, we don't have to look at it.
That's what they're saying.
Yeah. Yeah.
Yeah, just be an ostrich. Stick your head in the sand. Everything's fine.
That's funny.
But I will show them how to do it without it being all over them
Yeah.
and all over the bottom and everything like that. So.
Dr. Rufi, what do you think about the culture?
I love it. It's great.
Yeah.
It's between fellow doctor colleagues, as well as our admin team, assistants, hygienists. Everyone's just friendly and fun, and when patients come in, they can feel that, and it makes our end of things so much easier too. I mean, no one likes going to the dentist. But if you also enjoy, like, hey, this team is really nice to be around. It's a
Right.
good office environment. It feels nice. It looks nice. They treat me well. Everyone else is treating each other well. Everyone's just friendly. It's hard not to like that.
Right.
And it translates to those patients too, because I can remember this happening more than once where Carla comes to me and says, hey, can we get this person's tooth out? And it's like 5 or something, it's kind of late. I'm like, absolutely. And she's genuinely thankful. I'm like, well, yeah. So I'm perfectly willing to do it. And I guess that's part of that, what's good. But she's willing to stay. She's got to stay now.
Yeah.
And now we're helping the patient. And so I think it ends up always being about the patient, but because we're doing that, it just kind of, it always is going to end up making it a better experience for the patient.
For sure.
If you're all mad and pissy and fighting all the time, they're going to feel that.
Yep.
And then they're stressed even more. But I think it's a calming atmosphere and helpful. Like, again, giving the patient what they want. Hey, I want to get this tooth out. It's hurting me, or whatever it is. It's nice to be able to do it.
Yeah.
Not have any flack. When I had my office, it was always like, because we would go 8 to 4 with no lunch because they want to get off early. I'm like, yeah, I want to do that too. So let's go 8 to 4. But man, when that 4 o'clock bell rang, they're gone. Doesn't matter what it pays. Wait, we do it tomorrow. and it's never like about the money. That's the thing. It was always just about helping the patient.
Yeah.
And so Carla's really, I think, really good about trying to get the best interests of the patient, taken care of. So
I think my favorite thing about the office is actually Carla.
it might be.
Yeah.
She's okay. It's only because she's right over there.
She's amazing.
If you weren't there, we'd be saying all kinds of bad things.
But we all know we spend more time with our work family than our own family, and we might as well make it fun and nice. So
Absolutely. Oh, the one that kind of shaped you.
Oh yeah.
Yeah.
We'll end on this. What is the case as a doctor that has shaped you into who you are?
Well, I had to have help from Carla on this, so But I had a class 3 patient, and normally we wouldn't do that, but it was probably our first one that I tried doing Invisalign on, and it actually worked. He actually went into class 1 and
Wow.
normal
Wow.
bite.
Wow.
Dang.
And yeah, it worked. And
Wow.
and it was
Really?
stable, which was amazing. So
How long did that take?
probably a year.
Wow.
That's not bad.
Severe class 3?
It was pretty good. Yeah.
Wow.
Just not jaw surgery class 3, but
No, I mean,
yeah.
it could have, well, it reset, and
You didn't have to
Worked
flare too much then.
no, it actually looked really good. I was really shocked the way it passed through. There was a point where it's sitting there like that, and then it passed through, and then once it passed through into class 1, it was really stable. I don't recommend that you all do that.
And just so the audience knows, a class 3 is an underbite, as we're talking about. So it's an underbite to a normal bite.
Yeah.
Yeah, I
Like a piranha.
wouldn't recommend just trying to do that on
No, I
everybody.
think we'll just give those to you.
I will just give those to the
The orthodontist down the street.
orthodontist. Yes.
Like, just like on a technical note, did you have to do some kind of like, how would you do that with Invisalign, like turbos or something? Where you to open it enough to allow.
No, we didn't even do that.
Wow, got them across.
Yeah, and the crossover probably was only 2-3 weeks, and then it was.
Dang, that's cool.
It was
Wow.
there.
What about you? What's the case that?
I keep trying to think of something good, and the only thing I can think of is something that was negative that ended up good. And what it was when I first moved here, I was taken. You can strike this from the record if you don't want to, but I had to go to the board, and it was over a denture, and she just didn't come back for adjustments. And so what it did to me is going to the board sucks. And I was exonerated, whatever you want to call it. It was, it was no problem. But going there kind of sucked. And the way it shaped me was not so much to be fearful, like, oh, now I've got to be worried everybody wants to sue you or have problems with you. But it was more that I need to be better with my staff to make sure that we got her back. Like, I guess they were waiting for her to call or something. I said, look, you're going to need at least a few adjustments, whatnot. And I don't know that ever, it's not like you can just say that once to the patient, like the post-op instructions as an example. If you give that to the patient and they're leaving, they're just thinking, I want to get out of here.
Right.
So they're not always hearing everything. So if you don't do something where you're giving them post-op instructions written, your staff is following up with them, which I think is a big thing the next day or so, calling, hey, how did that go? Are you okay? How's the denture? So anyway, it shaped me more to try to turn the negative into a positive and try to just be better about taking care of people and being consistent and following up.
Communication,
So,
yeah.
yeah.
Yeah. Mine was a young woman, probably mid-30s, that did a lot of drugs in her past, and she had a kid or two, and just really missing teeth, bombed out teeth, and just in bad condition, and doing a full case of ceramics on her, and her parents helped pay for it, which was great. And just a transformation of seeing this mid-30s female, and by the time we were done with her, it was probably like 2 years, all said and done. Just a whole nother human. Able to get a job, able to provide for her family. I think she was a single mother, all that stuff. And just, in the case turned out really well. I had to work with the lab directly to do some gingival masking. It was really unique, but we got it done. And it changed her life, and it was cool to see. Yeah, this has an effect on people right away.
It really does.
Yeah.
Yeah. The one that comes to mind for me, this is less related to dentistry, but it humbled me, and it now keeps me very open, is I was working out of dental school probably in my second or third year, had no idea about holistic dentistry at this point, and had a patient come into my office, and this office was in network with insurance, and she asked me to do things more holistically, like follow this certain protocol. And I was like, you don't need that. It's fine. You know, we have all the section. We'll do it, you know, this way for you. Anyway, she ended up moving forward. I did remove her mercury filling, still having no idea about the issues with mercury poisoning. And then, you know, soon after that, I did end up getting sick and then learned all about it. But I kind of blew her off. And then later I was like, oh my gosh, I shouldn't have done that. I should have looked into this more. I should have humbled myself and like investigated what she was trying to tell me, because your patients do teach you a lot. And I will never forget that experience.
You were
So
a
now,
dental student?
no, I was out practicing.
Oh.
Yeah, I was out practicing. It was probably only maybe 2 years out practicing. And, you know, dental school poo-poos the whole holistic world. So
course.
you're kind of brainwashed into thinking this is the way, this is what's right. I know what I'm doing. Oh no.
And now look at you.
And now I'm like,
Yeah.
wait, what is that you want to tell me about? I'm always asking patients what they've learned, what they know, because people have a lot to teach you. And just because you're the doctor doesn't mean that you know everything.
Yep.
So
True.